Hi, good afternoon, everyone. Welcome to day 6 of our internship. Am I live? I can't see any of you here yet. Yes, there you guys are. All right, so good afternoon, welcome. Today's topic, as you all know, is neuropsychology. So, we'll be talking about neuropsychological assessments and cognitive retraining. It's a very, very niche, super specialized topic today. Can be very, very interesting once you understand it, once you explore it further. And today's expert is our very own Anuna ma'am. Let me just add her. So your favorite, as Sir keeps saying, anuna.bordoloi@fortishealthcare.com. So you have Anuna ma'am as the expert for today's session. Like I said, neuropsychology is a specialty which requires a lot of technicality, lot of knowledge, lot of ability to be able to apply what you went back and studied in your science classes and then in your physiological psychology, then you come to neuropsychology, and then to actually apply it within clinical practice. So it requires lots of expertise and knowledge, and we have Anuna ma'am to take care of this topic for today. Just to answer some of the questions that have been coming in every day about logistics, which both of us have been telling you, yes, you will get to discuss the assignment answers where both Anuna and me will be there with you on the last day on 15th, and we will discuss all the assignment questions on that day. And in terms of for notes, so we're trying to make these sessions more interactive, so you won't be able to get the PPTs, but the recording is going to be there at least till the 15th, maybe even later. We'll confirm that as soon as we know, because we need to figure out how much space we have on our drive to record and keep these session recordings live until then. But till 15th, they're definitely going to be there, so you can feel free to go back, replay, and make your notes. All right. So, like I said, extensive topic. I'm now going to take away more of Anuna's time. All yours.
Thank you so much, Roshni. Okay, so a very good afternoon to all of you. Uh, like you know, I'm Anuna Bordoloi. I'm a clinical psychologist, and today we are going to talk about a very, very interesting topic, which is on neuropsychology. Let me try adding the PPT. Yes, here we go. Okay, so yes. So before going to neuropsychological assessment and cognitive retraining, I feel well, many of you may have already learned about the brain and the nervous system and everything. But then before doing anything, the knowledge of the brain and nervous system becomes extremely important. Without that, you cannot do anything in neuropsychology. Right. So today we are going to learn about history taking. In neurology, history taking is a little different than the psychiatric history taking, so we are going to learn about that, and then we are going to learn about the brain, certain maybe lesions in the brain, how that occurs. Then we go to the neuropsychological assessments, and then we go to the cognitive retraining part. We will talk about what are the recent advances and how neuropsychology as a field itself is advancing. Then we are going to, yes, then we are going to go to the very, very interesting part, which are the assignments. So a lot of you have been asking about the assignments. Yes, towards the end of the session, I'm going to discuss that so that there is no confusion there. All right, let us start. Oh, some of you are asking for the attendance link. The attendance link is there on the description box, but we will try to put it on the comment box as well. Right? Okay, in some time we will do that. Now, let us go ahead with the slides. Yes, like Roshni ma'am has already, I think, shared the PPTs. Sharing them may not be possible, but we will have these links available as much, till the as much duration as we can, and you can come back and visit them all the time. And for assignments, I think we have received mail regarding that as well. So assignment link are going to be open till 15th 3 p.m. At 15th 3 p.m. we are going to close the links, and so that we can discuss the assignments. So okay, let us go ahead with the topic. All right. Now, the nervous system. So, just a second. Yes. So, the nervous system, we all know nervous system is divided into two parts. One is the peripheral nervous system, one is the central nervous system. We are going to discuss in detail about the central nervous system, particularly about the brain part. But before that, let us just uh, have a discussion about the peripheral nervous system, what it does. So now the peripheral nervous system is further divided into two parts, which is the autonomic nervous system and the somatic nervous system. Now the autonomic nervous system, what it does is it regulates the actions of certain internal organs and glands, and which is further divided into the sympathetic nervous system and the parasympathetic nervous system. Now the parasympathetic nervous system, what it does is uh, it helps in arousal matlab, let's say in old days, maybe cave days, you did not have that security. Right now we know all the doors are locked, we are sitting in a house, we are comparatively, we are danger free. But previously, let's say you are in a cave, you do not know a tiger attacks you, something else invades your private space. So sympathetic nervous system helps you in that arousal, that you need to act now. So in a state of danger, like we all know that fear is a very very primary emotion. So in those situations, sympathetic nervous system helps in the arousal, and it helps you either fight, freeze, or other things. Now, what? Let's say the danger you were aroused, you were able to fight the tiger, and now the tiger has gone away. So you now need to calm down. There becomes the parasympathetic nervous system's role. There comes the parasympathetic nervous system's role, where it helps you in calming down, right? Okay, now coming to the somatic nervous system, the second part of the peripheral nervous system. Here we have one is sensory input, and the second one is motor output. Matlab, all the senses coming through all these sensory organs. We have primarily five sensory organs, right? The visual, auditory, your visual, auditory, then olfactory, then gustatory, smell, right? So everything, all of these inputs, whatever it whatever we see, whatever we hear, all of these are taken care by the somatic nervous system, with the somatic sensory inputs, and then motor outputs control musculoskeletal movements. So whatever I'm doing with my hand, I'm raising my hand, or I'm walking, all these things are done by the somatic nervous system. Now, let us go in detail and learn about the just a second. Huh? Okay. Roshni, is there any issue? Someone is saying that some assignment link. Okay. All right. Fine. Okay, so we'll keep on coming back and checking the comment box. Let us stick to the topic for now. And I know it can be a little, you know, boring, but once you start understanding the nervous system and the brain function, it becomes extremely important. So I'll try to give some breaks in between, and let us see that. Just a second. Huh. So let us come back, and we will discuss. We will take few breaks, like sir has insisted on taking breaks, so we will take breaks in between. But let us first cover some part, then we'll take some break, and then we'll come back. Okay, now next, if you guys are having some trouble accessing the attendance link, just give me a moment. I think the attendance link is working fine. So, all right, now going back to the topic. Okay, now let us see the sympathetic and parasympathetic nervous system. Now this is a little more in detail about which part, how they function. Once we understand the brain and the spinal cord, and how they interact with the other nervous system. And so that is basically we have explained in this slide. It's a little bit in detail, but you can just remember the slide and it will help you in understanding this whole thing further. Okay, next. Now, remember the central nervous system. We said it comprises of the brain and the spinal cord. Now we will understand different parts of the brain and how it functions and what is the connection between the spinal cord and the nerve. Okay, let's see. Now, brain is the one of the largest and the most complex organs of the human body. It is made out of more than 100 billion nerves that communicates and trillions of connections that are known as synapses, right? We know synaptic clefts, how one neuron and the other, they interact between each other. So it is extremely important. I mean, it becomes extremely interesting once you go into detail and you learn how everything we are doing, like how we are speaking, how I'm moving my hand, or maybe we are communicating, you're writing, you're typing, everything is related to and everything is controlled by our brain and the other nervous system. Now let us try to understand a little more in detail about the brain. Okay, so brain, let us say, to understand it better, let us divide it into three major parts: the hindbrain, midbrain, and the forebrain. The hindbrain is the structure on the top of the spinal cord and just near the the cerebellum. So it is the structure on the topmost part of the spinal cord which controls the biological functions which we need to keep us alive. Now, the midbrain, it is between the hindbrain and the forebrain. It coordinates with the simple movements like with sensory information. Forebrain controls on what we think, we reason, all these primary brain functions. Okay, so this slide would help you in further understanding the divisions. Let us see. So the forebrain or prosencephalon, it can be further subdivided into two parts: the telencephalon and the diencephalon. Now, the telencephalon and diencephalon can be further divided into different areas. Please pay attention because this is going to be handy when you are doing your assignments as well, right? Okay, so the first one is the cortex, which takes care of our sensory, then perception, your motor and language abilities, everything, right? Then comes the basal ganglia. Now basal ganglia deals with our motor controls, and then comes the amygdala. Sorry, I pressed something, I think. Okay, then comes the amygdala. Amygdala is always, remember, it is primarily related with our emotions, right? Amygdala, hippocampus, we always discuss when we are talking about something related to emotional memory and all these other things. We are going to discuss it towards the end. Now, amygdala is primarily, it is related to our emotions. Then comes the diencephalon. From the on the forebrain, the subdivisions: telencephalon, diencephalon. Diencephalon is can again further has these parts: the thalamus, which processes all the senses except smell. So the senses are processed in the cortex, right? When we are going to discuss the cerebral cortex in detail, you will be able to understand. But before that, it comes to thalamus, and it sends it to the it chooses and sends it to the cortex. Then comes the hypothalamus. Now hypothalamus is again, it receives the messages from the nerve cells, right? Something happening, whatever is happening, it is like the mid boss before sending it to the big boss. It just receives it, and then it decides about what kind of hormones are also releasing. So all these things are controlled by the hypothalamus. Then something is called as the epithalamus as well. It mainly connects the limbic system and other parts of the body. Then there comes the midbrain. So midbrain, again, midbrain has three parts. It doesn't have any subdivision, but the three parts are the tectum, which controls movements and its connections to the premotor cortex. Now when we are going to discuss about the cerebral cortex, which we are going to do after this, you will be able to see that some of the sensory primary senses, it is taken care by our cerebral cortex. Different parts are there, so that takes care of it. When we are going to understand the low functions, then you are going to understand that. But before that, it the tectum controls movements, and it connects all the sensory input, all these inputs, to the premotor cortex. Then comes tegmentum. Tegmentum is mainly, it serves as a, like, it subserves as a cardiorespiratory, for cardiorespiratory functions. Then comes cerebral adequate. It's like the aqueduct. So it functions as a canal for our cerebrospinal fluid. So there are again different ventricles, the third ventricle, fourth ventricle. We do not need to go into that much detail, but we need to just know that the cerebral aqueduct, it serves as a canal for the cerebrospinal fluid. Now the third one, the hindbrain. So it is further divided into two parts: the rhomencephalon and the mesencephalon. Now the rhomencephalon is further divided into two structures. One is the cerebellum, which is, again, I think we know cerebellum is the structure here, the cauliflower-like structure. It has the functions like it coordinates, balances the body. It signals the body to adjust how, okay, let's say there is a slope, so how will you walk now? So all these things are controlled by the cerebellum. Then the pons, uh, near the cerebellum there is a pons, and the pons, it controls alertness, it controls pain signals. So let's say, this, you tap on your body, something we have felt here. So maybe this pain sensation, our pons is giving a signal to the through the spinal cord. The signals are reaching to the pons, and the pons is giving the signal that, oh, you just got hurt, so it pains here. Now then comes the medulla oblongata. It is a connection between the brain and the spinal cord. It mostly regulates the vital functions like the heart beat, breathing, etc. Right? Okay. Now this is done. Let us see where all these things are situated. Okay. All right. So these are the pictures, and so the first one is the telencephalon, the whole, the cerebral part, and then the diencephalon. The diencephalon, like you can see, just beneath the telencephalon, the diencephalon is located. So the shaded parts shows where the location of these areas are. The mesencephalon is further down than diencephalon. Then the metencephalon is behind the, you know, pons and the cerebellum. Then the myencephalon is the medulla oblongata, right? Okay, all right. Now let's understand the brain in more details. Okay, so the brain, yes, the brain is now, again, it can be subdivided into further parts, but I feel that if we can understand the cortex, we will be able to understand many things better. So the cortex is what the, let's say this is the brain, right? So the cortex is the outermost layer of the brain. It has many vital functions like thinking, voluntary movements, so many things are controlled by the cortex. Now then the brainstem is, like we have said, between the spinal cord and the brain, and the basic function of brainstem is like breathing, sleep, all these things, the vital, bodily organs, this is controlled by the brainstem. Then basal ganglia is a cluster of structures in the center of the brain, and the basal ganglia coordinates messages from multiple areas of the brain, where to spend, which area is going to react and what are we going to do. So all these things are coordinated by the basal ganglia. Then the cerebellum is again at the base and back of the brain. The cerebellum is a cerebellum is mainly responsible for the coordination and balance. Okay, so all right. Let us now see how I mean, let us now understand the brain. Now, let's see, this is the brain, huh? So, this is the most common, I think, the best way I feel that you can understand the brain. Let's say this is the brain. Now, this part is the cerebellum, right? Sorry, the cerebrum. Now, the cerebrum is the most, like this part. It can be further divided into four lobes that we are going to talk about, but first, the whole brain, the main, the mushy cushion like that part that is known as the cerebrum. The brain, that we have two hemisphere, the right hemisphere and the left hemisphere. That is divided by something called, when you see from the top, so the brain we can see, and it is divided in the middle, right? So it is divided from by the longitudinal fissure. It is the deepest fissure in the brain, right? Okay, so let us see what does cerebrum does. So cerebrum is, again, it controls memory, cognition, language, thought, judgment, reasoning, problem solving, certain motor, certain sensory issues, and everything, right? Then now when you see, there are certain ups and downs in the brain, right? So when we see the brain structure, let us see if we have any. So here only in the brain anatomy, you can see that few are like ups and few are downs. So the ups are known as gyrus or gyrus, we can say both, and the down are the sulcus or the sulcate, right? So these are these decide that structure of the brain, how the highs and lows go. Next, let's see the different. Okay. One thing I forgot to mention was that both the hemisphere, like once we dissect the brain, once we see that the central fissure, how it divides both the brains, but they both need to communicate with each other, right? So if they are completely divided, they will not be able to. This side will not be able to communicate with the other side. So they are connected by something called as the corpus callosum, right? Okay, let's see. Now they are further divided into all these, the whole cerebral cortex, that they are further divided into four lobes. Now let us see the lobes. Okay, so always see the frontal cortex, the frontal lobe, it takes most of the part. So like, this till here, it is the frontal cortex. Then this part is the parietal cortex. The behind that smaller part, that is the occipital cortex, and then there is the temporal cortex. Now let us see lobe wise what are the features that they do. Now primarily the frontal lobe, it is divided by the central sulcus, the first line that you can, the first broad line which is here, you can see that is the central sulcus, and there is one lateral sulcus, uh, which is known as the lateral sulcus. So it divides the forebrain, the frontal lobe, from the uh, parietal and the occipital, from the parietal and the temporal lobe. Now, let us understand the functions of the frontal lobe. Now, the function of the frontal lobe is, let us remember that frontal lobe function means, always remember action. Action, whether it is mental or it is physical, right? So, in mental functioning, in physical also we are going to understand, but in mental functioning, the most common, when we talk about the prefrontal cortex, prefrontal is again just the uh, primary part of the frontal lobe. Now when we talk about the frontal lobe, mostly one common thing you will hear is executive functioning when we talk about the functions. So executive functionings, what executive functioning does is planning, problem solving, motivation, judgment, decision making, impulse control, social behavior, your primary memory. So many things are controlled by the uh, frontal cortex. Now, these are the mental activities, right? What are the motor activities that is controlled by the frontal lobe is your skeletal muscle movement, your ocular movement, your speech control, facial movement. I'm doing this, or I'm throwing something, I'm walking, I'm speaking. All these things are mostly controlled by the frontal lobe. Okay, so yes. Now, if we try to understand it again further and subdivide it into different areas, so we have the primary motor cortex, and then we have the premotor or supplementary motor cortex, and then we have the, what is that called, the frontal eye field as well. Now all of these we just need to, I think, going into too much detail is going to be a little confusing, so we are just going to uh, stick to just remembering the function of the frontal lobe. When you are going for your further studies, I think going into detail will be easier for you, but for now we just need to remember that the frontal lobe uh, is what do we say, so the frontal lobe is primarily, the function of frontal lobe is action, whether it is your mental action or it is your uh, physical action. Now, when we talk about physical action, let's say this is the central sulcus, and the area adjacent to that, that is the primary motor cortex. So the big muscles like the foot, leg, your trunk, arms, face, all these are controlled by here. Then the premotor, like the area before the primary motor cortex, so it controls the planning and coordination of movements, right? Then the frontal eye field is more with the voluntary or rapid eye movements, so like I'm rapidly blinking, all these things are controlled by this part. Then the prefrontal cortex is, again, like I said, prefrontal is the most developed one, so it controls our executive functionings, behavior, personality, everything. Now here only one more very important area is situation, which is known as the Broca's area, which controls the muscle of speech. So production of speech muscles, whatever we use, that is controlled by the Broca's area. Okay, let me know if I'm going too fast or I'm going into too much detail. Let us see. Hmm. Okay, someone is saying neuropsych is not my strongest point. Well, it is a little complex, so we first need, we first learn psychology, but to practice psychology or neuropsychology, for neuropsychology, definitely you need to, know the nervous system and the brain. But then for psychology, also understanding what are the brain areas, what are the brain areas that are there, how the neurotransmitters work, how it affects our psyche, everything. We It is helpful when we know about the brain. Okay, someone is asking me to go a little slow. Okay, I'm sorry about that. I will try to go as slow as possible. Right? Okay, let us go back to the discussion. Okay, now let us discuss the now so far. If because I was going too fast, if you're not able to understand me, let us go a little slow. So the frontal, we were talking about the frontal lobe. So the frontal lobe is the fore part of the brain. Like this part we have discussed, the primary function of it is the uh, is action, whether it's mental action or it's physical action, right? All right. Hmm. Yes, is Broca's aphasia related to the functioning of frontal cortex? Yes. Then somebody is saying any specific function of gyrus and sulci. Okay. Then again, so it is mainly the area and sulci we do not see specifically as its function. We The functions we are going to understand lobe wise only, but it helps in segregating the areas, right? Like the central sulci is the main sulci which divides the frontal and the parietal lobe. The lateral sulci, it divides the what do we say, the temporal and the frontal lobe. Now, let us go to the parietal lobe. Now, the parietal lobe functioning, we have parietal lobe. Let us understand whenever you hear parietal lobe, let us understand the main function of parietal lobe is somatosensory. Now, somatosensory is awareness of our somatic sensations: touch, pain, temperature, pressure, vibration, and some sensations like some memory related to somatic sensation. When I got hurt, it pained that much. So all these things are taken care by the parietal lobe and the sense of proprioception. Now, this is a very interesting term. I think there is one book where they have discussed in detail about the sense of proprioception, very interesting, which is known as the uh, man who mistook his wife for a hat. So there's a very interesting story about the sense of proprioception. Now, what that helps us, like how the sense of proprioception helps us, is knowing where which area is located where. Now, let us do one exercise. I think, okay. So I can see the terminologies you are finding it a little difficult. No, no worries. We are going to, try to keep it as simple as possible. Rest of it, I think I have already written it down, so you can just go back to the slides and you can see it. Okay, coming back to the interesting part of proprioception. Proprioception is the sense of knowing where each part of our body are, right? Now, close your eyes for 1 second. All of you, wherever you are sitting, close your eyes and touch your nose. Close your eyes and touch your nose. So, even with close your eyes, you were able to touch your nose. You didn't have to see where it is. Close your eyes and touch the other hand. So, you will be able to do, right? So, even without seeing, it is the sense of proprioception which tells us where each of these areas are, right? Okay, so again, I think parietal lobe is also like it has different areas, but let us not go into that much detail. We just need to maybe know the names. So like the somatosensory association cortex, the primary somatosensory cortex. But we just need to understand that the at this level, you just need to know parietal lobe is, uh, the functions related to parietal lobe is the somatosensory functions, right? Okay, now parietal lobe is done, the yellow part done. Then let us come to this small part at the back of the brain, which is known as the occipital lobe. Now, occipital lobe is it has functions primarily related to vision, right? So the we whatever we see, what information from the eyes, that the information goes to a particular part and then it sends to the occipital lobe. So all the functions that is related to vision are taken care by the occipital lobe. So like anything processing and analyzing some visual information that is going on, or understanding some visual stimulus. Now the picture of the lobe that I'm showing you, that is going to stay in your head, right? So these kind of images and understanding, you whenever now you see the brain, you will be able to see that, oh, this is the frontal lobe, this is the parietal lobe, this is the temporal lobe, this is the occipital lobe. All these things you will be able to understand when this picture stays, and your occipital lobe is going to help you in memorizing that any visual stimulus that we are getting. Your occipital lobe is uh, you know working to get that information to you and analyze that, and helping you to memorize that. Now the last one, the temporal lobe. The temporal lobe, let us see what the temporal lobe does. It is mostly related to the function of auditory stimuli, hearing sounds, any pitch. I mean, you can at times see what was the pitch, and somebody is singing in a very high pitch. All these things, what is the frequency of that sound, all these things, and processing all this information are primarily done by the temporal lobe. Other than that, again, I think, yes, I have mentioned about the uh, Broca's area. Now, along with Broca's area, there is something that is known as the Wernicke's area. It is situated on like towards the top of the temporal lobe, and it is between the parietal lobe and the temporal lobe. Wernicke's area does what? It helps us in comprehending or understanding any spoken or written language. Now, whatever you are studying, whatever you are seeing in the slide, and you're listening to me, and you are trying to comprehend everything, that means your Wernicke's area is functioning and helping you in uh, with all this information, right? Okay, so that is that. Now, mostly all the, what do we say, all the sensory information, uh, the vision, smell, sorry, the vision and the other sensory information, that is, as I have shared, that is taken care by the other lobes. Now there is something which is situated deep within the lateral sulcus. Matlab, let's say if this is the lateral sulcus, I hope you're able to see. So deep inside this, there is something which is known as the insular cortex. It is again, uh, it is responsible for taste, autonomic control, and so on and so forth, right? Okay, now if we go beneath this cortex, we find the limbic system, right? So limbic system, it has the singular gyri, it has the amygdala, hippocampus, all of that. And I think amygdala, hippocampus, thalamus, hypothalamus, we have already discussed. So these are these formulate within the structure of the limbic system. Okay. And if we have to understand the function of the limbic system, we just simply can remember that the limbic system is related with the functioning of your learning and memory, right? With all the other structures, it helps us in with the function of learning, memory, emotion, and behavior. So if somebody asks you where the, which area of the brain takes care of your emotional memory, maybe you can say that these are the areas that takes care of the emotional memory. Now again, I understand that brain is very, very complex. It becomes very difficult for us to remember all this information that we are learning, so it can become a little frustrating. Let me help you with a simple revision again. Remember this, just your fist, the frontal part, front is the frontal lobe, right? Then the behind the central gyri, it is the parietal lobe. Parietal lobe is all the P's: proprioception, pressure, pain, position, all the P's, right? Proprioception, pressure, pain, position, all the somatosensory things are taken by the parietal lobe. The frontal lobe is action. Action is motor functioning, executive functioning, everything is taken by care by the frontal lobe. Then the parietal lobe. Parietal lobe is all P. P is proprioception, pressure, pain, position, all the somatosensory activities are taken care by the parietal lobe. Then comes this part, the small part, occipital. So occipital is related with vision, right? Temporal, mostly hearing, right? Okay, so there we are done with the lobes, right? Okay. All right, let us go to each of the functions, like just quickly skim through each of the functions. We have already discussed about this. Somebody is asking, you spoke about aphasia. Aphasia is again your inability to speak because of certain lesions in the brain. It can happen due to brain trauma. We are going to go there. We are going to, when we are going to talk about the lesions, we are going to go and talk about the aphasias, right? Okay. All right. Okay. I'm glad that some of you are able to find the explanation helpful. Now, again, quickly let us go through the functions of the frontal lobe. The frontal lobe, generally higher executive function, emotional regulation, planning, reasoning, problem solving, all of that, right? Okay. Temporal lobe. Temporal lobe is primarily auditory, and some visual processing happens through the temporal lobe, and memory is also taken care by the lobe wise. Memory is one function that is taken care by the uh, temporal lobe. But do not get confused, vision, always remember occipital lobe. Some visual processing is taken care by the temporal lobe. Then the parietal lobe. The parietal lobe is the sensory part, right? It is separated by the central sulcus. We have discussed the it is responsible for integrating sensory information like touch, pressure, pain, temperature, proprioception. Remember, like where's the nose? Oh, here. Where's the ear? Oh, here. Right? Where are your eyes? It's here. We do not need to see. Where are my eyes? I don't need to see. Right? Okay. All right. Then parietal lobe. Yes, occipital lobe is again primarily visual processing of the brain. So, by looking at a well, we are able to see how deep the well is. Right? At least we will have some idea. I think this is at least 6 feet. Right? The distance. I think this is at least 11 foot. Right? So all these things, this part of the brain, the occipital lobe, is helping us in understanding that. Okay. All right. Now we need to go to the brain lesions. Do you guys think we should take a break, or we should go ahead with the brain lesions, and then we will take a break? Yeah, let me know. Can we go ahead? Break. Okay, one person is asking for break. 5 minutes break. 5 minutes break will be too long. Let us. Oh, somebody wants to continue. Okay, let us take 2 minutes break. All right, 2 minutes break. Okay, we settle with 2 minutes break. Come back. Okay, I'll be here, but whoever wants to take a 2 minute break, I'm going to pause for 2 minutes. Okay. All right. Okay. Uh, Before continuing, maybe some of you are not back, so let me take few questions. The functions of amygdala, thalamus, and hypothalamus. Well, see, thalamus, you can. I am not sure if I can give you any mnemonic, but thalamus, remember, as a filter before the information, the sensory information that is coming from our spinal cord, which comes from different nerves and different nerve cells. Before going to the uh, before going to the cortex, the thalamus filter, matlab, it's like it processes it and then it sends it to the uh, cortex. Amygdala, emotion. Amygdala is always emotion, right? Then the hypothalamus is just, you can remember as, okay, if this is the brain, how do I show? Okay, let's say how do I show? Okay. So if this is the brain, so the outer layer is the cortex, and inside the limbic system is there, right? In that also there are different areas. So the hypothalamus and thalamus, they are tiny, tiny areas inside this limbic system. So the hypothalamus, it helps in connecting the whole limbic system. So in a way, it controls the whole limbic system. It connects with all the other like brain areas, right? are all four lobes present in the rest? Yes, both the hemisphere we have all the lobes present. With see, someone is asking about the Wernicke's and Broca's aphasia. Now, if that specific region which affects the Wernicke's, the speech, the comprehension of speech and reading material. If that only that specific area, let's say some tumor is developing, something has happened, some lesion has happened in that particular area, then only this part, what we say, comprehension will be affected. So if lesion in only Wernicke's area, then the comprehension part is going to be affected. If lesion is only Broca's area, then it is going to be affecting your production of speech, right? So, but generally, let's say if there is a brain trauma, let's say there's a hit to your head, so the frontal part, generally only one function. It is very uncommon that only one function is going to be affected, because in head trauma there will be multiple function. But yes, in terms of other types of lesion like tumor, if it is happening in one particular area, then only that area will be affected. Now going ahead with the presentation, let us see. Let us understand the brain lesions. Oh, I have already explained some of them, but maybe few of you might be wondering what are brain lesions. I didn't realize that I have not explained that. So let us go to that detail. Brain lesions are nothing but a type of damage to some part of the brain. Now, it can be due to disease, due to trauma. Trauma means head trauma. Head trauma means head injury. Do not get confused with other trauma. Other trauma means in in psychology, what the trauma that we use. So, lesions can be due to disease, head injury, some birth defect, or like tumor. Also, I'm considering in some infection or disease only. So, infection, tumor, all these things are within that disease only. Sometimes brain lesions can appear in one specific area, like I have explained in Wernicke's and Broca's aphasia. At other times, these lesions are present in a large part of the brain tissue. At first, brain lesions may not produce any symptoms, but they may worsen with time, and the symptoms may be more noticeable. Like let's say if there is a tumor on the Broca's area, so the speech might be slightly affected, right? Okay, I am not able to maybe find the right word, or I'm not able to speak as much as I used to, but it is not that much. But when the tumor starts growing, then maybe the symptoms become more noticeable. That's why in these cases they are not, because they are not symptomatically so evident. Many a times, till the time the tumor becomes big, or the infection becomes so big that it affects other parts, or it affects that function completely, it doesn't come into notice, right? So that's why until and unless we do certain test, it doesn't become very visible. Okay, so brain lesions can be caused by many different triggers. The following factors can put a person at risk for brain lesion. Now, aging. This is going to be very interesting. Somebody might ask that, if somebody asks that, can aging cause brain lesion? The answer is yes. With aging, like other parts of the body, brain areas also, brain neurons also start dying, and that can cause lesions. If you have some family history, like in any other illness, I think if you have some family history of some disease, infection, anything, right? If that is present, then you are more at risk. Any vascular condition, epilepsy, right? Fits. So epilepsy is like, I think the best example I have always found is earthquake. It is like an earthquake in the brain. So it starts shaking, and maybe if that happens, then also there can be many damage to any part of the brain. That's why we can see cases where, let's say, if you're a clinical psychologist, You will get cases where your they are going to come to you for maybe IQ assessment post seizure. Now that will happen. Maybe there was no problem. There was no problem initially with the child developmental. There was no developmental delay. Everything was fine. But when when the child, maybe he was 1 year 2 years old, then they started having seizure, and since then his development kind of seems like the development is not age appropriate. Then you finally get them to the OPD to get their IQ tested. So with epilepsy, maybe this can be an example of a case where brain lesions have developed with epilepsy. Trauma to the brain, trauma, again, head injury, right? Some different kinds of infections that can create brain lesions, tumors, autoimmune diseases, some plagues due to again some infection or some other disease, exposure to repeated radiation or to certain chemicals, to so many toxins, and poor diet can also contribute to the development of brain lesions. Okay. Okay, let us see now again lobe wise. Let us see what are the lesions that can develop with different lobes. Okay, now mm, with the frontal lobe lesions, what are the functioning that can get affected? All the functioning that is controlled by the frontal lobe, that is going to get affected. So so many cases you will see post brain post head trauma, this person's behavior has changed. The person, the you know there will be complaints by their spouses, maybe reduced, I mean different difference in their sexual behavior. Behavior is again one of the functions that is controlled by the frontal lesion. But sexual behavior, if you are taking properly history, then you will be able to find, from at least from the informant, that with frontal lobe lesion, primarily with the personality change, you will see that there would be change in sexual behavior as well. Social behavior, so like we say that they will come and tell you that they were not at all like this before, but now they have, there is a dramatic change in their behavior. They do not, you know uh, they do not seem like the person that used to be there, right? That it feels like that the person is not there anymore. Difficulty in interpreting feedback from the environment, any nonverbal maybe cues, difficulty in understanding and taking appropriate steps, fewer spontaneous facial movements, and speaking of a few words. Again, the Broca's area and the facial movement, we have studied that it is a function that is we have discussed that it is a function that is taken care by the frontal lobe. So we have difficulty in facial movements as well. So many a times in many neuropsychiatric disorders, we will see that the patient the patient's facial expression can be blunted, can there can be flat effects. So I hope that while studying case study, you have paid attention to all these terms. And we in MSc we do see all these changes. We need to notice them closely, and we need to report it in the MSc. So with frontal lobe lesions, the facial movements or the facial expressions can get affected. Okay, then let's see. Then let's see the temporal lobe lesions. Now, a lesion in the temporal lobe can affect your change in behavior and emotions, disruption in the sense of smell, taste. So we have seen that the deep one, which is near the just above the temporal lobe, so there the sense of smell and taste and hearing, because hearing is one again primary function that is taken care by the temporal lobe, that gets affected. language and speech disorders, problem with the field of vision, again because of the close proximity to the occipital lobe. At times the vision can also be compromised, and as we have studied that some part of the vision that is taken care by the temporal lobe as well. So lesion in temporal lobe can lead to problem with vision as well, and forgetfulness and the inability to focus. Okay. Again, do not get confused. Attention is a function of the the frontal lobe, but forgetting memory is a function of the temporal lobe. That's why forgetting and difficulty in paying attention, it may look like they are not paying attention, I have to say over and over again. So that can happen due to frontal lobe lesions. Now, the parietal lobe, remember this, how do I show it? Yes, this. So, this is the brain, the first part, frontal, this part, parietal, right? Divided by the central gyre. And now we are talking about some lesion, some damage to the parietal lobe that can, I mean, we have understood that it is the sensory motor cortex. I mean, it takes care of the sensory motor functions. So, some functions like the mm, loss of sensation, like touch. I am touching it here. If you touch your own body, you can feel it, right? And how the shirt feels. If you're getting the air, how the air feels on your face or on your body, you can sense it because the parietal lobe is functioning. It is providing you with all this information. It is so amazing when you know, when you start thinking that I have just touched, and the brain is so quick. It has already given you the message that somebody is touching you. Maybe when while walking, maybe somebody hits you and you immediately react, right? So how fast the brain has to be to give you all this information. Isn't it that fascinating? Well, I find it very fascinating. So again, loss of sensation like touch, stereogenesis, or inability to identify things placed in hand. So like let's say, okay, let's say this is the phone. I'm placing it on my hand. Even if at times when we do neuropsychological assessment, we have few tests where we ask the person to close their eyes, and they can, ask them what is the to identify the object. Right now, let's see. I have two objects here, and I got it to show you for the neuropsychological assessment part. Let's say this is a token, right? So if somebody places it in my hand, and if they say that what is the shape, even without looking at it, when I look at all, I mean when I touch all the corners, I'll be able to tell that, oh, this is a square, right? So similarly, like with the easily identifiable, or on day-to-day basis, whatever we use, if we place that in the person's hand, usually they are able to identify, right? So that is the functioning. And with parietal lobe lesions, that can get affected, plus the weakening of language development. Okay, let us go to occipital lobe. Now, occipital lobe primary function, mostly, I mean, it is just related to all these things, vision only. So, changes in vision, visual hallucinations, lesion in the parietotemporal of occipital lobe is associated with color agnosia, movement agnosia, and agraphia. See, there are very few functions that the occipital lobe does on its own. Mostly, it communicates with all the other lobes, and then it functions. So, the only function, if you say, then it is always related to vision. Many visual hallucinations can be present because of the lobe in occipital lobe, or changes in vision, or your blindness can also be there due to some lesion in the occipital lobe. Okay, then let's go to the, okay, now understanding to understand I think neurocognitive disorders. We are going to go post this. We are going to go and understand about the how do we take history in neuropsychology, and how is it a little different than the rest. So we are going to learn about that. But before it, we need to understand when we suspect a organic mental disorder or neurocognitive disorder. uh, when somebody starts maybe having some symptoms for the first time, and at what at what age that the person is coming to you, and mostly with neurocognitive disorders, then it is sudden onset, right? In psychiatry, I think other than very few disorders, you will not find something which is like, which has a sudden onset. Even in, in many dementias also, it is, the onset is very gradual. But in many other neurocognitive disorders, the onset can be sudden. But like I said, like in dementias, the onset can be gradual as well. uh, Many a times the person may come with manic like symptoms. Now I hope that because you have already gotten that class in psychiatric disorders, you know what a mania is, or what manic symptoms are. You have already read about the psychiatric sorry the bipolar disease. So many a times at an older age, a person, if they come with bipolar like features, then again we need to rule out so many things before we diagnose them with bipolar disorder, right? So we need to, generally, if at an older age a person is coming, we first need to be very very careful to rule out the neurocognitive aspects. History of drug and alcohol use disorder. Again, whatever people may tell you, all these use uh, alcohol, your nicotine, cannabis, or any other drugs, it always have adverse effects, right? At times, people can say that can, like, single use cause some problem. The answer is yes, it can, and it can have a lifetime effect. So we need to be very very careful when we take a decision about the use. Now, any ongoing medical or neurological treatment, because at times it can be some drug effect, it can be due to some ongoing or long term medical illnesses. Now, can anyone tell me some illnesses, some physical illnesses that can lead to some neurocognitive disorders? Very very common ones, एक बारी बताओ. My question is, can anyone tell me some physical illnesses that can lead to neuropsychological deficits? Sorry, neurocognitive deficits. Parkinson's. Parkinson's, well, Parkinson itself is a neurocognitive this thing. Brain tumor. Brain tumor, again, I'm keeping it as a neurocognitive disorder. Some physical, other parts of the body, can something which has happened in the other part of the body can lead to some neurocognitive deficit? Yes, very good. Stroke, right? Stroke, mostly a cardiovascular problem. Like, we know that there is there is vascular dementias as well. So stroke can lead to neurocognitive deficits. Other than that, head injury, of course, we have already discussed that. Hypertension, very good. So hypertension can lead to stroke eventually. And long term, one more you guys are missing. One more, very common one. Any guess? Accident, trauma, paralysis. Well, again, paralysis is due to something happening here. Our body is not responding. Anything else? Stroke, hypertension, we have discussed. Hormonal imbalance. Well, depends how why it is happening. Diabetes, very good. So yes, long-term diabetes can also cause some neurological diseases, right? So diabetes, hypertension, if there is long time or long term, that can, not in all cases, but in some cases, uncontrolled diabetes, hypertension can lead to neurocognitive disorders. Okay, going back to the PPT. Okay, so neurological symptoms such as seizures, impairment of consciousness. Now, again, we are going to understand the level of consciousness in the coming slides. So, I will explain it there. Head injuries, sensory or motor disbalance. All of these things we need to check when the patient is coming to us, right? Then, presence of confusion, disorientation, memory impairment, or some other soft, like not very evident neurological signs. When we do the detailed MSc, we will be able to figure them out. And some prominent visual or non-auditory hallucinations. Again, auditory hallucinations. Okay, let us take all this also as a question. Auditory hallucinations are most common in what kind of illnesses? Auditory hallucinations are most common in what kind of illnesses? Hallucinations we have studied. We know with all five sense organs, hallucinations can happen. And depending on which type of hallucination is, which sense organ is affected, involved, we can have auditory, visual hallucinations. Yes. So, auditory hallucinations are most common in psychiatric illnesses, right? Visual or other, kind of hallucinations can also be present, but mostly in psychosis, schizophrenia, or maybe some bipolar disorder with some psychosis, or some other disorder with psychosis can also have these auditory hallucinations. But whenever there is a visual hallucination or non-auditory hallucinations, then we again need to rule out the neurocognitive factors, right? Okay, well, I'm happy with the responses. It seems like you are paying attention. Okay, let us move ahead. These are some of the broadly categorized huh. These are some of the broadly categorized disorders that are found in neurocognitive problems. Deliriums are again acute. It can change in hours to days. It is, but it can be persistent to weeks and even months. Dementia, traumatic brain injury due to infection, some brain infections. We can have neurocognitive disorders. Substance substance use that we have already discussed, and any other medical condition, like you have said, hypertension, diabetes. All of these can cause some neurocognitive deficit. Okay, so all right, till here we have understood the brain lesions, how the brain functions. Now let us come to neuropsychology, right? What is neuropsychology? Neuropsychology is a branch of psychology which deals with how a person's cognition and behavior are related with the brain and rest of the nervous system. So, when you hear the word neuropsychology, you need to understand that neuropsychology is simply nothing but the brain and the behavior, the connection between the brain and the behavior, right? So, how a person's cognition, behavior that is related, that is affected by something that is happening here, something that is happening here, how it's different than psychiatry. In psychiatry, there may not be any organicity. Matlab, uh, let's say I'm having non-epileptic seizures. They are called like okay, like some, okay, I'm having fits, but when they have done all kinds of neurological tests. There is nothing wrong with any particular area. So without that organicity, if the symptom is happening, that is um, psychosomatic, right? So we just need to understand that something that is happening, why it is happening, which area of the brain is involved and responsible for that particular function. It focuses on understanding the relationship between the brain and the behavior, and it provides diagnosis and treatment for behavioral and cognitive effects on neurological disorders. Now, again, for the longest period of time, neurology, you know, particularly in in neurological conditions, the primary treatment was medicine. Now, also, it is the primary treatment is medicine, but uh, recently with the development of neuropsychology, we have now so many interventions that can be done and that can make effective changes in the person's life. Like somebody with stroke, okay, fine, you maybe removed that blood clot, but to return to their daily functioning, what do we do? Do we do nothing? Do we just do physiotherapy? No, we can do so many neuropsychological interventions based on the functioning that is affected, which we will get to know through neuropsychological assessment, right? So that's how the importance of neuropsychology is coming in. And in clinical settings, neuropsychologists work with individuals who have brain injuries, neurodevelopmental disorders, or neurodegenerative diseases. Neurodegenerative diseases, matlab kya? Where the brain lesions are gradually developing due to neurodegenerative can be like not due to aging, but with maybe due to conditions like dementia. It can be Alzheimer's, it can be vascular dementia, it can be maybe frontotemporal dementia. There are different types of dementia. So a neuropsychologist works with all these problem areas, even in neurodevelopmental disorders. Okay, here we come to neuropsychological case history and MSc. Now, more or less, it is similar to the psychiatric history taking, but few areas we will need to pay a lot of attention because it is different than the psychiatric history taking. So let us first understand the history part, and then we will go to MSc, right? Okay. So neuropsychologists are clinical psychologists with specialization in neuropsychology. So far, yes, because we do not have any specific training. Although in NIMHANS there is one, but yes, because I feel that you need to know about psychology and basic psychiatry to be able to differentiate, because the neurologist is going to call you in to understand and maybe help with the diagnostic clarification to understand whether it is psychiatry, whether it is whether it is a psychological problem or it is a neurological problem, and you need to have the basic knowledge of clinical psychology, in my opinion, again, to have a neuro to function as a neuropsychologist, because it helps aids you in so many other areas. And so far, there is no individual neuropsychology degree, in my knowledge. In few universities, they might have started. Uh, but yes, well, that is my answer. But somebody might differ. All right. Now, case study. So we first, description of the present illness. Again, listen to this very, very carefully. You have some assignment regarding the same, so try to understand it. I will try to explain as much as possible. I'm not expecting you to know everything within one day's class, but just to give you an idea so that you can practice, you can understand better. So I have kept this as an assignment. Okay, so description of the present illness. Nature and date of onset, like we have said, it is mostly sudden, but it can be gradual as well. So nature and date of onset, duration of the illness, for how long they have been having these symptoms, description of some behavioral changes if it is associated with the illness. All of these things comes in description of the present illness, like you do in CC is the chief complaints in psychiatry, right? Okay. Then comes other relevant organic brain symptoms. So if there is any unusual behavior, or if there is any wandering behavior, wandering matlab purposeless purposeless movements, right? Or maybe nocturnal movements, like you are suddenly getting up and going and wandering, then evidence of poor social judgment, where you are not able to discriminate how to behave from, differently from one situation to the other. Like here I have given the example of discarding new clothes in trash, and being verbally abusive as a social gathering without having any provocation, right? So that can again indicate towards some organic presence of some organic symptom, but again we need further evaluation. Oh, all right. So, evidence of poor social judgment, and this information should be obtained from someone other than the patient. Because if the patient is coming with a social impairment, we cannot rely on the data that he or she is providing, right? So, in these cases, we need to take help of the informant. Attention and concentration problem, that would be very evident. We are going to do the MSc, and even if they say that, आजकल बात बिल्कुल नहीं सुनते हैं, or whatever I'm saying he completely ignores. So these kind of comments, if they are telling you, that we need to take into account of. Then the language problems are like word finding difficulties. आपको कुछ बोलना है, आप मुझे वो चाहिए, वो many a times it happens to us, but it can be due to at times anxiety. We are not very present, many of us, we are not present at the moment, so we have word finding difficulty. But this will happen consistently with a person with some cognitive deficit, right? Okay. Word finding difficulty, comprehension deficits. The informant may say that whatever I say, they seem not to listen to it, and they do not understand it, so they will ask again and again. So then problem with academic difficulties like reading, writing. Somebody, if they are functioning at a certain level, then they should be able to do the basic reading, writing, calculation. But if there is some deficit it is developing, then they may not be able to do so. Memory difficulty, if you ask, again we are going to check in MSc, but if the person comes and says that he gets confused a lot, now this thing has happened way back, but he says as if it has happened yesterday, right? So these kind of memory difficulties, they may come and report, and it can be again with recent or remote memory. So difficulty with geographical orientation, getting lost. They do not, maybe difficulty with let's say dementia patient, or with any other neurological illnesses. There can be difficulty in finding their own home. Let's say, from the gate to your home, it's a simple route. You have to cross these 2 3 buildings, and then maybe you get to your apartment. So they may have difficulty in that. Or from the nearby shop, you every day you have been finding your home, but today you are having, like recently you have started having difficulty in that. Then difficulty with yes, geographical orientation we have shared. Trouble driving or carrying out simple tasks, as maybe using, I know that I have to touch this button for the microwave, or for the oven, or for this particular thing, which is a little complex than the switch on and off, but they have trouble in that. And driving also, maybe they will have trouble, right? Okay. Then any psychiatric history of any psychiatric illnesses. if there is any psychiatric symptoms that is present or that was present, if they had history of depression, anxiety, delusions, agitation, anything, if at present or it was present before, we need to take that also into account. Then past history, any previous neurological diseases, psychiatric problems, any other medical diseases, drug, alcohol use, any, like we said, there's so many diseases can be related to, can lead to neuropsychological deficits, right? So we need to understand and take a detailed history of their past medical conditions, right? Okay. Then head trauma, if it has happened like few days back, or maybe some time back it has happened, or if this person had a stroke in 2000, let's say 6 2016, anything that has happened in the past, although after that the person was fully functioning, he was absolutely fine, but it can have some correlation. So for that we need to mention everything that was present in his medical history in the past history column. Then there comes birth and developmental history. Now, any deficit at birth, whether the birth was with full term, whether it was full term, preterm, if it was preterm, why? Whether it was normal delivery, C-section delivery, if C-section delivery, why? Uh, and if there were any delays after birth, if there were any infections after birth, if there were any trauma, anything after birth, if they were what do we say, if they were incubated, NICU after birth, we all of these we need to take into consideration. And if there were any delays, now post birth history is done, then we come to the childhood history. So in that, any developmental delays in motor functioning, let's say, oh, everything was fine but he walked a little late. How late? By what age did he start walking? Or everything was fine but just there was a delay in speech. Now delay in speech means, what was the problem? Like, was there bilingual parents? Was there any, was there nobody at home to talk to the child? Why there was a speech deficit? Then intellectual delay, academic, if they had any learning disability, maybe dysgraphia, dyscalculia, anything that they had, that we need to take into account. Then we need to see any emotional or social problems that they had, like, okay, the child had autism when he or she was diagnosed with autism when they were 3 years old or 4 years old. So anything that has happened, or maybe they had selective mutism, anything they had, we are going to mention here in the childhood. Okay, then comes educational and vocational history. Educational history, I think we have already learned in the class of case history and MSc. So, educational history, again, from the childhood, any gap, anything, how good of a student he was, how academically how he was, everything we are going to uh, maintain here. Then we come to the employment, the vocational history. So vocation is what type of jobs that this person has done, or did he change his jobs frequently? Was he able to maintain his job roles? Was he frequently having difficulty with his job roles? And uh, let's say for some people, no, they were absolutely fine, they have maintained this job, the company has been extremely supportive, they have been able to maintain well, but recently they have started having problem at work. Let's say this person is he has excellent relationship with all his employees or all his colleagues, but recently he has started fighting with the colleagues also, the attendant might tell you. So again, we need to take into consideration of everything, and that is not possible until and unless we are taking a detailed history, right? Okay, then comes the family history. Family history में there is did I leave anything? Okay. So family history में there is the neurological or psychiatric diseases, if there was any history like any genetic history, if there was anyone in his family who had some previous psychiatric or neurological conditions, again that gives us a direction in which way we are going to see, because genetic factors play a very very significant role. So we are going to see whether there were some neurological deficits, some psychiatric diseases in the family members. if there were history of, let's say, इनके ना दादी को था वो भूल रही थी, कितने एज में भूलना शुरू हुआ था, यू टेक द हिस्ट्री, यू गेट टू नो दैट ओके 65 70 at this age दादी started forgetting. Now that can be a strong indication that the same thing might be happening to this person as well. It can be, Alzheimer's, it can be vascular, it can be anything. But we need to take the detailed history of neurological diseases. Familial predilection of particular disease processes that may involve central nervous system, like we have discussed, hypertension, stroke, anything that has happened in the past also, like it may not be recent, he may have had history or he may had a stroke previously, that also we need to take it into consideration. And if his any of his family members have had history with stroke, his father, his somebody died of an heart attack, or they had after the stroke they started behaving like this, that can also give us a uh, that can give us again some help in the that can aid us in the process of diagnosis. Okay, before going to MSc, let us take a short break. Yes. Oh, somebody has already asked for a break. All right, fine. Let us take a short break. This time we are going to take 10 minutes break. Yeah. Okay. Let us do that and we'll come back. Okay. In 10 minutes. Yeah. Okay, are we back from the break yet? Okay, before we go ahead with the presentation, let me see if you have asked any questions. Break, break, break. Yesterday's assignment. Okay, so yesterday there were no assignments, so there is no assignment link. Anything that we provide, the attendance or the assignment link, you will be able to access it from the description box. So you simply need to go there and access it. If it is not there, that means there is no assignment for that day, right? And many of you are asking about the assignment of today. I mean, you are asking these questions over and over again. So I guess you are not, what do we say? You're not attending these sessions maybe regularly. So if that is the case, then just doing the assignment and, attending without attending, just filling up the forms, well, that doesn't, actually give you any learning, isn't it? So if you're just here for the certificate, I mean, you are going to get it, but then you're not going to learn anything. So what's the point of this whole thing? So the fifth day assignment link, it will open when we finish this discussion, and I'm going to discuss the assignment as well. But to do the assignment, you need to attend the class. So let us try to be a little more patient, and let us try to now focus on the class, right? Somebody is saying that I'm on mute. I'm not. Rest of you, can you hear me? Okay. Yes. So you can hear me. So whoever is not able to, maybe you can check your own connection. Oh, yes, somebody has corrected me. That is true. Yesterday it was a psychological assessment. Thank you. So there was an assignment for yesterday, but for day before, there was not, right? So today is the sixth day. There was an assignment for fifth day, but there were no assignment for fourth day. That is correct. I stand corrected. Thank you. Okay, let us now go back to let us go back to I have asked you a question before. Okay. Because you are asking a lot of questions, I might have missed. You can ask the question again. What is this? Okay. What if the caregivers are not able to uh, give full family history? Then we make use of whatever we have. We cannot do anything if somebody is not able to, give you and information. If they do not know, then they do not know. But if they are able to give, if that is available, we just need to ask, because it helps us in understanding the case better. Okay. All right, let us go back to the presentation. Now we have discussed about case history. We have learned how to take case history in a neuropsych. Now let us discuss about MSc. Again, MSc can be extremely detailed in neuropsychology, but as we are going to discuss about the test, and right now you may not be able to go into that much detail, so we are going to learn a very very brief version of MSc today, right? The first is level of consciousness. So level of consciousness, we need to understand the alertness, lethargy, if they are on an alert state, if they are on a lethargic state, if they are on a stupor stage, if they are on obtudation state, or they are in a coma. We need to mention everything, whatever we observe during this MSc period, right? Okay, then comes behavioral observations. Now, again, in behavioral observations, we need to just a second. Huh. So, in behavioral observation, we need to see what is the behavior, what is the behavior of the person is saying. Like when we see that the person, if they are in coma, then there can be some MSc that is possible, but many of it maybe we will not be. Okay, so MSc is mental status examination. Like in psychiatric, I think psychiatric history and MSc we have already learned about it. So in neuropsych also it is similar to that, but it is a little different than the psychiatric history taking and mental status examination. So coming back to my point, we have discussed about the level of consciousness. We have discussed about whether the person was alert, lethargic, they were a little taking very less from the environment, they were on a stupor or semi-coma state, where they might be looking at everyone but they are not responding, or they are in a coma state where they are not alert at all. So now, um, again, we come to the behavioral observations. So behavioral observations, we need to see the history of behavior change. Like this we will cover a little bit in the history part, I mean the clinical case history part, and that is going to give us some insight into this, like when did the behavior changes started happening, if there is any memory difficulty, if the person is showing any bizarre behavior change in any work habit, or if how the person physically appears, what is their posture, how they are, what is their gait, what is their physical appearance, right? All of that we are going to cover in behavioral observation. Then the emotional status, are they in a confused state, they do not know where you are when you ask ki aap kahan ho, if whether they are able to understand that or not, whether they are able to respond to that or not. And if they are extremely anxious, and they, or they are frequently, their emotion keeps on changing, it becomes very difficult to maybe figure out what they are feeling. And again, some frontal lobe test results, like many, there are many, like the fist finger test, or there is some drawing test that can be done to assess the behavioral observation. Again, we are going to discuss this in detail when we are going to discuss about neuropsychological assessments. Then comes and if there is any awareness of the problem, if there is complete denial. And again, in many of the cases there will be denial because the person is not aware of the um, changes that has been happening, right? Then we test the language through verbal fluency test, where you can ask like let's say given 1 minute and you can say as many words as you can, and then sentence repetition, you say something, you ask the person to repeat that. Then word naming, just name these few things around me, maybe what is this, then what is a pen, or maybe what is this, something, or maybe what is this. So like some things around you, you can ask, and if the person is able to uh, name that or not. Then memory, again, recent, remote, immediate memory. Recent may you can ask about what they have, what they have eaten. Either that is going to be mentioned, if the person is in IPD, that is going to be maintained in the chart, and if they are coming with coming to OPD, you can always ask the attendant, what have you had today morning, last night, or maybe who came to visit you yesterday. All this recent information. And then in remote we can ask about their birth date, their relationship, or when did you pass your matriculation, when did you join your service, and maybe if you do not have any attendant to check whether they are saying the correct thing or not, maybe you can ask, okay, when did you pass this, okay, around this, so around maybe 2010, who was the prime minister or who was the president, and if they are able to think back and they are able to tell you, of course we are going to give them some time, and that means their remote memory is again intact. And like I always I think, give importance to that before doing the MSc, we need to be very, very careful about the person's educational qualification, their background, and everything, so that we are able to ask the right questions, right? If a person doesn't have any, anything to do with the outside world, let's say if they are, let's say, they live in a rural area where they do not have many outside connection, and let's say he is his mainly livelihood is farming, so they may not have some political interest, so they may not know the president or prime minister's name. So then you ask questions regarding whatever they do on a daily life, maybe ye crop kab hota hai, and when you collect the crop, which season is best for this crop. So these kind of questions which they are familiar with, right? Okay, so that is remote we were talking about. Then we have some immediate memory, like you can ask about, you can again say a sentence and then you can ask it in some time, so that can also test your immediate memory. Then comes abstract functions. So abstractability we can check with some calculations, like it can be graded addition, subtraction. First it can be verbally, that okay, 11 plus 22, what is that, or 22 minus 11, what is that. So we can ask it first verbally, then again on writing as well. Then proverbs and similarities. So in proverbs and similarities, we have, let's say, okay, we ask them that in proverbs we give them a proverb and we ask the meaning of it. Let's say in Hindi, naach na jane angan tedha. So what does that mean? If the person says नाच न जाने आंगन टेढ़ा, मतलब नाचना नहीं आता है और आंगन टेढ़ा बोलते हैं, that can indicate in functional or towards a concrete abstractability as well. But what is the real meaning? If they are able to go through that okay, you do not know how to do the job, but you are uh, putting it on the circumstances, or you are blaming the circumstances because of which you think that you have failed. So all these things, if they are able to say, then maybe we can say their abstractability is at the conceptual level, right? Okay, then comes similarity. Again, to check the abstractability, we can see similarity, we can give them certain objects and we can ask them the similarity or difference between them. Like, oh, okay, you give them two things, let's say uh, bike and a car. What is the similarity between them? So if they say that okay, they both help you in transport, right? So you use them for transportation. Then let's say we give them what else? Okay, fly and the butterfly. So the main similarity is that they both are able to fly, right? They both can fly, they both have wings. So depending on their abstract ability, they will be able to give you the answer. Now till here there is one assignment which you are supposed to do, and I'm going to explain it when we share the assignment link, right? Okay, so till here we have covered neuropsych case history and MSc. Now let us go to, okay, somebody this is very interesting. I could only see the last comment. Okay, So one of you have said that I do not know. Nowadays, we do not know the Hindi proverbs. No problem. You ask them in English. If your client, can understand. If your patient can understand English, you ask them in English. Rolling stone gathers no moss. There's so many proverbs. If they're able to understand, then you ask them in that same language. But if you're practicing in a Hindi speaking population, then you will have to learn, right? You cannot, because you do not know, you cannot blame the person that, oh, he doesn't know the meaning of this. He is not fluent in English, that is not his fault. So you need to learn the language that you are the population that speaks the language. That's why the cultural factors become so important in psychiatry and neuropsychology. Somebody is saying, Fish, is it a good book? Yes, Fish is a very good book to understand psychiatry primarily. For neuropsychology, I have recommended few books towards the end to understand maybe neuropsych case history and MSc. That I would say, you know, I think Shrub and Black is a book that is extremely helpful. But again, I have shared the links towards the end of it. I have mentioned the book names. You can check there. Now, let us go to the assessment part. So, now we are going to understand neuropsychological assessments. So, neuropsychological tests are the test which aids in the whole neuropsychological examination from MSc, like psychiatric or psychological disorders. From MSc, whatever we can get, we can, if based on that we are able to formulate a diagnosis, well and good, we don't need anything. But post, if there are some diagnostic clarification further that is needed, then only we are going to go for further testing like psychiatric illnesses as well. If we need some further diagnostic clarification, we are going to go for psychological test. If we need some diagnostic clarification in neurological cases, then we are going to go for other neurological testing. It can be MRI, it can be CT, it can be EEG, and it can be neuropsychological assessment as well. So for neuropsychological assessment, we have two goals. One is to identify the disrupted psychological component, process, or domain in an individual patient and arrive at a profile of adequacies and deficits of psychological functions. The second one is to identify the brain structure, functional networks that are dysfunctional and damaged using the neuropsychological profile that has been derived. And finally, this information is used to lateralize and localize the brain lesions. So we need to first we use neuropsychological assessments to identify the disrupted psychological component, if there is any, on the individual patient, and we arrive at a you know uh, at profiling the individual. And then the other functioning is, through the functional assessment, we try to see which brain area is affected, right? So through the testing, we will be able to find out, let's say, okay, this particular area, Broca's area, or this functioning is affected. So that means premotor cortex is the area that's affected. So through the functioning, we will be able to localize the brain area. Right? Okay, let us learn about some neurological assessments that are available. So, the Luria, Nebraska test is a well known worldwide used test. It is a standardized test that identifies the neuropsychological deficiencies by measuring functioning on 14 scales. It evaluates learning, experience, and cognitive skills. This test helps to determine the location and specific brain lesions. It is graded on scales that are correlated to the regions of the brain and helps us identify which region is damaged. The second goal of the neuropsychological assessment. And it has 269 items divided among, as we have already said, 14 scales. So these areas are motor, rhythm, tactile, visual, receptive speech, expressive speech, writing, reading, arithmetic, memory, intellectual processes, pathognomic left hemisphere, right hemisphere scales to understand the functions of each hemisphere. And it is each of these scales are rated from 0 to 2 on this continuum. From 0 presents normal or no damaged brain, and 2 depicts high damage. But again, this is a universal test. Many parts of India also we may use it, but we have certain Indian adaptations, so we generally uh, use that particular test. Now, the second test is Halsted rated neuropsychological battery. Now, again, if we go on dividing neuropsychological test on different spectrum, we will find some flexible tests, we will find some fixed stress tests. Now, fixed tests are those where you will have to administer the whole battery. Flexible tests are those where you can use parts of it depending on what exactly you are trying to find. Let's say you just want to find out the attention of this person. In Halstead, you cannot do that. You will have to administer the whole battery, but in NIMHANS or in what do we say, Allen and B, Luria, Nebraska, we will be able to uh, use that particular test, right? So that's a flexible test. The Halstead is a, what do we say? It's a fixed test. It is developed by Halstead in 1935 to study neuropsychological patients in his laboratory. And Creighton adopted Halstead's methods and various test procedures. With them, established a laboratory in the University of Indiana, and he supplemented these tests with a number of additional procedures in order to obtain greater comprehensiveness. 6 to 8 hours it takes to administer. It is a comprehensive fixed battery, and each test of the battery is independent. Okay, for this one test, it's like these are 5 categories. So one category can be administered independently, but we cannot take one just subdivision of it and then administer that. So the core tests are the category test, tactual performance test, seashore rhythm test, speech sound perception test, and finger tapping test. Okay, now let's go to our very own NIMHANS neuropsychological battery. NIMHANS neuropsychological battery, the latest version is 2004. It is a comprehensive battery developed for assessing the cognitive functions of Indian adults. It was developed in NIMHANS, which is in Bangalore in the year 2004. The objective of NIMHANS, the neuropsychological assessment, is to chart the deficits and adequacies of the underlying cognitive emotional areas and voluntary or non-voluntary behavior. Now, like I said, we have Indian adaptation of these tests, so we use the Indian adapted one. So NIMHANS neuropsych is based on Luria's method, and it is the first neuropsychological battery that was developed in the country. The latest version is in 2004, but the first was way back. I forgot the year, but I can check and get back to you. Okay, so this is okay. I can see that this is not very clear, but I just wanted to give you what are the areas that is there in NIMHANS neuropsych. Let me see. This is better. Okay, so there are 19 tests on the NIMHANS neuropsych battery. It takes minimum 3 hours, so 3 to 4 hours to administer, and the age range is from 16 to 65 years. Now, to know the test, let us go to the other one. Yes. So let's see what are the tests and what are the functions that it measures. To measure speed, we have the finger tapping test, but speed is, again, we have mental speed and we have motor speed. So for motor speed, we use finger tapping test. For mental speed, we have the digit symbol substitution test. I will try to show you. I have my booklet here. I'll try to show you how it looks like. Okay, I have this page which shows the so this is digit symbol substitution, right? So we have all these symbols, and we asked the person to put these symbols, and we note the time, how much time they are taking. Finger tapping is again, there is a device where you need to tap with your index finger, keeping all the other fingers stable, sitting on the table, and you tap with your finger, and it is done with both the hands, and we take the average time. Then color trails. In attention, we have color trails where we have numbers given in different colors, and we ask the individual to trail from one number to other. I have another this thing here. Okay, so it looks like this, right? And you will find some examples maybe on online as well, like for color trail, not enhanced color trail, but then you can find some online as well for color trail test if you want to see. Okay, then comes digit vigilance. Now digit vigilance is a test of attention. So you ask them, it's a test of sustained attention actually. Color trial is a test of focus attention. And so in digit vigilance, we give them two numbers, and we ask them to cancel those numbers, and we again see what was the number of errors along with the number of time taken. Sorry, the total time taken. Then we have the triad test. So the triad test where two stimulus are given at the same time, and the person is asked to uh, differentiate between or like tell you both. So let's say I'm giving you three words. You need to tell me which is the odd one out. At the same time, I'm writing a number on your palm, and you need to tell me what number I have written, right? Then few tests for executive functioning. COA again. COA is controlled oral word association test, which measures verbal fluency. I have come to this slide because the functions are written in detail here, so that you can also see. But I'm going to tell you if you're not able to see the slide clearly. Okay. Then animal naming test, again an executive functioning test, and it assesses category fluency. So you give 1 minute time, and you ask them name how many animals that you can name with one. With the verbal fluency, you give a letter. Let's say the letter is P. So tell me as many words as you can with the letter P. Pen. And if you are starting with English, you will stick to English. If you are starting with Hindi, you will stick to Hindi. So let's say pan, pen, pin, right? So within a specific span of time, how many words you can say with that same category, same letter. Design fluency, there are again design fluency test where you ask them to draw certain designs. Working memory, we have visual working memory, and we have verbal working memory. For that, there are specific tests where they are given a task, and they are asked to follow it. Then for planning, the Tower of London is a very famous test for planning, where you need to figure out how you are going to go ahead executing this task. Then there is set shifting. So Wilkinson, again WCST popularly known as, it's a very famous test for set shifting. It is difficult to explain it, but I have few cards to show you. So there are different cards like this, right? And you give them a set of cards. They need to match it with the cards that that is given to them. It is again very, very interesting when you get to do it in detail. It becomes very interesting. Then comprehension, the token that I have shown you already. So this is a comprehension test. You give them the tokens in different ways you present the tokens, then you give certain commands. Let's say, first maybe you can say where is the blue token, where is the yellow token. Then you may say that okay, point at the bigger token. Then you may say that put this near that. So increasing the, what do we say, with increasing complexity, you try to uh, see the verbal comprehension of the person. Then learning and memory. So we have verbal, for verbal learning, we have AVLT. AVLT is again auditory verbal learning test, that you give a list of words to the person and they need to assess, they need to tell you how much ever word they are able to retain, right? Okay. Then there is a passage test. Passage test is also a test of like logical memory, as we call it. So as we uh, you know as we can we give them a passage, we will read that passage to them and we ask them to reproduce how much ever they could retain. Again, there is a time gap. First can be immediate, after some time it can be a delayed response, then you may ask them after half an hour. Visual, again similar, you show them a complex design, you ask them to first copy and then maybe you ask them to further, what do we say, like further produce that design from their memory. Okay. So we have these three age groups. So we have norms accordingly available for the NIMHANS 2004 battery. We have a category for literate and illiterate. So we, for literate, there are three parts each of them. So the age group they have divided from 16 to 30, one age group, and norms are again separate for that. And in that also, in the literate category, they have divided into further two parts. One is secondary education, then there is college education, right? So 16 to 30, then 31 to 50, then 51 to 65. Same goes for the illiterate category, and the norms are different from for male and female. Okay. Yes. So again, scoring is different for different subtests, as we have discussed. Raw scores, that needs to be checked with the percentile scores from the table based on that category that we have just seen. There is a table for each of the category. We need to look at that, and then we will be able to arrive at the result. And generally, below 15% is considered as a deficit area. So when we find a deficit score, that indicates towards you know functional domain, then we go to the cluster of functional domain and we reach to a neuropsychological syndrome. So it indicated one function, then different tests indicated different functions, then we get a functional cluster of functional domains where their deficit is. Then we go to formulating a diagnosis that okay, these are the areas that is involved, so most likely this is the diagnosis that can be made. Right. Okay. So there is NIMHANS neuropsych battery. The old one is again, uh, old one is again available. So it has these tests. So it was very lobe specific. So it had test for eliciting lobe dysfunction like attention, different tests for attention, test for visual search, mental set, and again psychomotor deficits. Then deficits in working memory, deficit in ideational and design fluency, deficit in visual spatial planning task. So in visual spatial, we can have BGT. I think I have discussed. Yes, I have a different slide for BGT as well. So we are going to discuss it then. And then we have different kind of, in the NIMHANS old battery, we have different kind of amnesias and expressive speech deficit and voluntary and involuntary uh, functions as well. Yes, so that is for uh, frontal. Then for the temporal one also, there are tests which measures visual integration, visual and verbal learning and memory, then some visual retention, all of this. And then parietal lobe, for parietal lobe also we have visual spatial perception. For again, for that we can use either the block design test. Okay, I don't have the blocks to show you right now. And we can see some sort of, if some sort of apraxia, which is ideomotor difficulty, or agnosia, visual or maybe verbal, sorry, visual agnosias, if that is present, we can see from the enhanced neuropsychiatry as well. Now that was the old version. Right now we are using the 2004 one. So there is the enhanced neuropsychiatry for children as well. Uh, so it is again adapted for from the Luria Nebraska battery for children, and the age range is from 5 to 15 years for the Indian population. Uh, It examines the functions of frontal, parieto-occipital, and temporal lobes, and it can take 2 to 3 hours each sessions, and we do it mostly in 2 to 3 sittings. So because children may not be able to sit for the whole duration, and they generally, they will not cooperate, so the results will not be effective. So we will, we will do it in 2 to 3 sittings, and there are total of 22 subtests. So these are the subtests of enhanced neuropsych battery for children. There is CPM. We can do CPM or SPM. CPM or SPM is children progressive matrix, or standard progressive matrix. Then we have the color cancellation. Do you remember digit vigilance, where we cancel the numbers? So for children we have the color cancellation test. Then we have phonemic fluency, we have test for expressive speech, design fluency, color trails. We have discussed about this. Portuous maze is like, again, any other maze, you find the way out. uh, Working memory test, verbal and visual NBAC, and working memory span, visual spatial working memory, then memory for design, and for auditory memory, long term or short term, we have RAVLT. Oh, yes. So we have a very interesting task here. Now I will go to the comments as well. Yes. Okay. So I have a task for you. Very interesting one. So to see how we do SPM, CPM, I have few sample cards from SPM, and I want you to comment as fast as you can with the correct answer. And the person who gives the correct answer and who says it first wins. Okay. Let us do that. Otherwise, it gets very boring, isn't it? Huh. Okay. Let us show. So here is the what are you guys seeing? You need to buy the, where will you get neuropsychological tests? Oh, yes, you need to see, these are, we are sharing with you for training purpose, but you have to be a trained professional to be able to conduct this test, and you need to buy this test. Once you go to buy, they will ask you for the license number and everything. So once you are a trained professional, then only you can buy and conduct this test. Okay, and you have access to these videos for at least quite some time. So let us not worry about that. Let us focus on this, and let's play this game. Okay, all right. Tell me, what is the answer for this card? So you can see the blank box. Which number do you think will fit the blank box? The one who gives the answer fastest. Okay, we have answers coming in. Huh, it's interesting. Okay, go ahead. we have variety of answers from 3, 4, 5, 6. Okay. The correct answer is 4. Just check it once before I change the slide. The correct answer is 4. Check it once. Why 4? You will be able to understand. Yes. Understood? Okay. Let us go ahead with the next slide. Okay. Now tell me, which one do you think is the correct answer? Think carefully, huh? This is getting harder a bit. Now it is going to get a little complex. Answers started coming in. 5. A lot of you are saying 5. 8. Okay. 8. Somebody is saying 8. 1, 6. Okay. 1, 1, 1, 8. Okay. Yes. The correct number is 1. Now, again, I'm giving you some time to check why it is not 8 and why it was 1. Why it is not 8 or 3, but it was 1. Okay. Next. Ready? Yeah. Go ahead. The correct answer. I think this is easy. Yes, I think all of you have got it correct. So the answer is 3. The third one is the right answer. Right? Okay. We are going to the next slide. That's the last one. Wait. Stop messaging now. Let us go to the next one. Ah, tell me what is the correct answer for this one. Hmm. Someone said 7, 6, 1, 8. Okay. We are getting various answers. I think for the speed, you are missing the accuracy. Ah, a lot of you are saying 1, 1, 1, 1, 1. Okay, yes. The correct answer is 1. Now, again, I'm going to give you a minute to check why it is 1. It was 1. The correct response is 1. Just check why it's 1. Yes. Okay, got it. Very good. Now, see, this is a SPM sample card that I wanted to give. Now, this is a test of your problem solving skills and logical reasoning, right? So, at times, these kind of test you will get in any other test, maybe any competitive test also. You will be you will be asked these kind of logical reasoning questions, or these kind of problem solving to test your problem solving skills. where the speed matters, but the accuracy also matters a lot, right? Okay. Oh, we will need to maybe hurry a bit. Now, this is again PGI BBD. PGI BBD is PGI battery of brain dysfunction, and it was developed by Dr. Dwarka Prasad and Dr. S.K. Verma from PGI Chandigarh. The age range is from 20 to 69 years, and the subtests are the PGI memory scale, battery of performance test of intelligence, which has the course block design and pass along test, verbal adult intelligence scales known as VACE, and information, digit span, arithmetic comprehension. These are the four subscales that is there with the VACE, and Nahar Vision test and Nahar visual motor gestalt test. Right. Then we have the Wechsler Adult Intelligence Test. So, ways, I think you have already studied this yesterday. So, I'm just going to quickly go to the subtest part where we have, yes, so we have four scales. So, we have the uh, verbal index, we have the perceptual reasoning index, and we have the working memory index along with the processing speed index. So all of these, they have different tests. For the verbal one, we have similarity, vocabulary, information, and then we have a supplemental subtest, which is the comprehension. For the perceptual reasoning index, we have block design, matrix, and visual puzzles, and the supplementary ones are figure, weight, and picture completion. For working memory, we have digit span and our arithmetic. The supplementary test, supplementary means if we are doing, if somebody is due to some deficit, if they are able to, if not able to do the core test, then we can do the supplementary test, right? So the supplementary test is letter number sequencing for working memory. Then we have processing speed indexed, where the core subtests are symbol search and coding, and the supplemental subtests are number cancellations. So I think ways was taught to you yesterday itself, so I'm not going to spend much time there. And we come to the whisk. Whisk is Wechsler intelligence scale for children. Then again, we have all these four categories, and we have subtests similar to the adult one, but it is specifically developed for children, and the norms are developed for children. Now, why we are talking about ways and whisk is we can take few subtests from here and we can use for neuropsychological assessment as well, right? Okay. Now, the most common test in neuropsychological evaluation is MMSC. Now, mini mental status examination is a 30 point. There are total 30 points. It's a 30-point questionnaire. Again, it is very important for your assignment. So, listen carefully. It is a 30-point questionnaire, and it is used extensively in clinical and research setting to measure cognitive impairment based on a certain if there is any indicative of a cognitive impairment, then generally we can go to like detailed cognitive evaluation. So, to estimate the severity and progression of cognitive impairment, and to follow the course of cognitive changes in an individual over time. So, MMSC, like MSC, can be done, you know, with more frequency, and if a person's state is changing from different times of the day or in days, it can be administered then I mean at different times as well. And it is originally introduced by Falstein in 1975 in order to differentiate organic from functional psychiatric patients. So the score out of 30, if you get 24 or more, then it indicates normal cognitive functioning, but mild deficit if there are less than 24 scores. Uh, I mean, indicates towards cognitive impairment. Okay, so this is the category and this is the description. Now, MMSC is easily available online, although there are certain corporate issues, but it is available. So, you have an assignment where a case history is given to you, and you are supposed to do MMSC and calculate the scores. So, try to do that, and you can refer to this table as well, where I have mentioned like how the points are divided, right? Okay, then comes BGT. So BGT is again a very common and very accurate, sorry about that, my throat is braining a bit. Okay, so the BGT is a rapidly administered screening test. It is a paper pencil test, and there are 9 index cards. The patient is presented with the series of cards, and they are asked to just copy it. Based on their performance, they're able to reproduce the designs. We can have different you know ideas about integration, distortion, preservation, rotation, whatever they are doing. It can indicate towards certain deficits that can be present in the person, right? Okay, let us see. I have just given this. I know this image is not very clear, but I could not show you the cards. So these are different cards, right? And it is presented in this order. Like the card A, you can see it is presented in this order. If the person rotates it in a different way, then also there can be some impairment that can be indicated, right? So your you have one assignment regarding this as well. That's why it is very important for you to understand, and you can maybe refer whenever you are doing the assignment. You can refer to this uh, these cards and just this picture. That is the main reason why I have put this picture here, so that you can refer to this and maybe you can find out whatever I'm asking. Okay, so the interpretation, again, we have rotation, we have overlapping. Rotation is more than 80-degree, and overlapping, if on one figure, on top of one figure I'm putting the other figure. Closure, if there is difficulty in closing, if it's if it's whatever form it is, and then we are having difficulty in joining all the dots, that can indicate a problem with closure. Then angulation, if there is uh, not 80-degree rotation, but there is some you know rotation. Generally it is considered from 45 to 80-degree, so that can indicate towards angulation. Then fragmentation is if they're not able to see the whole figure and they are doing it in bits and pieces, that can indicate towards fragmentation. Now, BGT, this was taken from the lac scoring system, but if you I mean, there are a lot to it. Even lac has given a lot of interpretation. This is just for your understanding. I just wanted to show how the interpretation of BGT is done. Some other test of neuropsychology, like Edenbrook's cognitive examination, popularly known as ACE. So ACE 3 is that we have. It has five major areas. The first one is attention, memory, fluency, language, and visual special abilities. So there are again different tests. I think I'm not sure if it is available online, but then you will again need to purchase this to be able to administer it. Then there is Minicog. Minicog is similar to MMSC. It can be used as an alternative to MMSC as well. So Minicog is again, it needs to see your like if there is any cognitive impairment, and if it needs any further detailed neuropsychological evaluation. So then there is frontal assessment battery, popularly known as FAB, and then there is CATS. CATS measures your you know daily activities, and CATS is more of the more common, like bathing, eating. It understands about these kind of daily living activities, whereas the IADL, which is instrumental activities of daily living scale, they go into more detail, like more instrumental functioning, like maybe you're able to do the finances or you're able to use the mobile phone. So like some more detailed activities they try to see, and we can assess these skills to see the current daily functioning of the individual. Along with this, we can administer personality test as well. We need to administer personality test and cross-cutting measures for your to rule out or to see if there is any comorbid psychiatric condition along with the neuropsychological condition. Okay, so that brings us to cognitive rehabilitation. Now, see, it is comparatively a newer area, but it is an approach to fit individualized needs, employing a problem-solving framework to empower people with organic conditions leading to neurocognitive decline to participate in and manage everyday activities, optimizing their functioning, retaining as much independence as possible. Now, again, whenever we listen to the word rehabilitation, we need to understand that rehabilitation is facilitating the person in managing or in developing their independence. We may not bring back the entirely whatever has been lost. If possible, we will try to bring that back. If not possible, with the current deficits that you have, how much can you uh, how much can you function as independently as possible. So rehabilitation is all about that, and cognitive rehabilitation is, it doesn't differ much from that. So this approach is characterized by a positive perspective into enabling individuals to utilize their functional abilities and to the fullest extent. All right, let us see what kind of cognitive rehabilitations we can do. And before going there, we have, I think, commonly used term. We often use cognitive training and cognitive rehabilitation interchangeably, but that is not correct. So first let us see what cognitive retraining is. Cognitive retraining is the process of, let me just quickly see the comments as well. If you Acha, okay, it looks like you all are with me. So I'm going to give you a very interesting task as well. So keep your paper pencils ready, or well, you do not need paper pencil actually. Fine. So you can just maybe type the answer. All right. So now for 5 more minutes, let us focus on the theory part. Then we are going to do something fun. Okay. All right. So, cognitive retraining, again, cognitive retraining is the process of setting and addressing goals through the number of stages. And the stages can be first determining whether the where the person stands, what are the deficits that they are having, then identify the areas to focus on, like if the person has memory difficulties, the attention difficulties, their participation in activities, their family relationship, wherever you need to focus, you are going to identify that. Then identify specific issues to focus on. For example, remembering the names of people when we meet, when or we are participating in an activity. So then comes establishing the baseline level of performance, whatever is their current level of functioning, we need to establish that. Like any other test that we do, we have a baseline assessment. Like in research also, maybe you all are learning when you are going to learn your when you are going to do your thesis. If you have some maybe experimental topics, you will see that we always need a baseline to compare that how much progress has happened, if at all some progress has happened, right? So to understand the baseline performance and identify the goal expressed in clear behavioral terms, like what exactly are you trying to achieve from this activity, that needs to be clearly communicated to the person or the attendants. Identify what level of performance will indicate that the goal is wholly or partially achieved. If we can share that clearly with the attendant or the patient initially, only there is no room for confusion. And I think they also have clearer expectation that how much they can expect from this whole process that they are coming and doing. Then plan the intervention to address the goals, implement the intervention with appropriate attention to the emotional responses or contextual issues, so that that is also getting solved. Like for example, if you have some behavioral issues, so you will design certain intervention. Or let's say you have a problem with response inhibition, you are not able to inhibit your response, and you say some inappropriate things anywhere. So maybe we are going to design certain task which targets that specific area of the brain, and then we try to implement that. Monitor progress, adjust the intervention if we see that, oh, during the course of our training we have seen that this has not been very effective, then we should be able to adjust it also accordingly. Then then we evaluate the outcome of the intervention and decide if they need further if further intervention, or it can be stopped, or if that can be carried out at home. Um, some home-based interventions that you teach the attendant so that they can practice whatever it is. After the evaluation of the intervention, you are going to share with the attendant and the patient. Okay, so difference again between cognitive training, like I have introduced cognitive training and cognitive intervention. Cognitive training is always with the targeting of the impairment. Cognitive rehabilitation is participation restriction, like mostly about whatever problems that you're facing. Cognitive rehabilitation is about that. Then context is the structural. In cognitive retraining we do some structural task and environment. Cognitive rehabilitation is mostly with the real life setting, like at home, what are the activities that can be done to accommodate them better. Then focus of the intervention is in cognitive training mostly isolated cognitive abilities and processes. In rehabilitation it can be group cognitive abilities. The format in cognitive training is individualized or group. Like if I'm targeting attention, then the same thing can be done with 10 people or individual. But in cognitive rehabilitation it is always individual specific. Whatever problem that you're having, I'm going to target that. Proposed mechanism of action, mainly restorative. In cognitive training, sometimes restorative means whatever functioning has been lost, we will try to restore that. And sometimes the combined with psychoeducation and some strategy training. In cognitive rehabilitation, a combination of restoration compensatory approaches, like if your right hand is not working, then can we train your left hand, or we try to combine approaches with psychoeducation and strategy training. Goals: improved or maintaining ability of specific cognitive domains. Rehabilitation is performance and functioning in relation to collaborative goals, like whatever goals that we have set before. So whether we are able to uh, take that forward or not. All right. Yes, few now cognitive training task. The first one, we are going to, again, it is a vast field now. Digital cognitive training is coming. And I mean, we are trying to understand how digital cognitive training also works. But let us just understand the basic things. So the first one, let's say for attention. For attention, to develop attention, what can we do? There are letter cancellation tasks that you cancel any two given letters randomly on like in a paragraph or in different on an area of letters. Like let's say there is A B C D written on a specific page, and then you give that to cancel two letters. Number cancellation, same, give two numbers, give, and you what do we say, we cancel these two numbers. And again, we will record the time taken and the accuracy each day. With practice, ideally it should be better. Then passage writing, write a passage from a book, and maybe you have certain number of letters each day you can practice to see the accuracy, and again how well you are able to do it maintaining a specific rhythm, like maybe appropriate font size and rows. I think here we come. Yes, here comes the practice. Let us go to the comment box. Okay, now I'm going to show you the next slide. Instruction is that you need to count the number of the letter A in this paragraph. In this whole paragraph, you need to count the number of A's that are present. Let us start. I can see you all are giving different answers. I'm really enjoying this. Go ahead. Okay. By the way, you do not need to count the link. Okay. This is just I have given for the source. Right. Okay, let me give you a hint. It is in the 60s house only. There is no 70, 80. Okay. Okay. Now, this is one interesting activity. I think you can carry on whenever you are doing it, during your daily lives as well. It is a very good activity to enhance your attention. So maybe you can do it as a daily activity with older newspapers. You can just choose a paragraph and you can start canceling the letters, right? So I'm going to give the point to whoever has given 64 to 66. So 64, 66, whoever has you know given these answers, let's say they win. Okay, next is cognitive retraining. We discuss about okay, just a second, where did it go? So next we discuss about verbal fluency task, like we have done in MSc. We can do that. You tell me as many words as you know with this particular letter, and maybe we just give you 2 minutes for it, and then the average number of words ideally should increase. Then divided attention, so you give maybe 9 symbols, and then you give the 30. There should be, like, this is a particular task you can design according to the level of the individual that is currently there. So then you can ask them to put each row, you can put like number of letters that is there. Now, okay, where is it? uh, okay, so the next one is we have ah so with divided attention we have then we go to information processing. Again, grain sorting can be a great task, or card sorting. It can be a great task to enhance in information processing, where the simplest can be you give different size, different color grains, and you give them to segregate it. Like, maybe you have given different dals, and then they can segregate it depending on the deficit. You can design that activity, and then you can ask them to segregate it, and maybe you can increase the complexity with the number of variations in the size of the grain and the color of the grain. Okay, then comes planning and organization. For planning and organization, we can develop so many block design. We can use the block design test along with the maze test, and we can give them some planning, some task which requires planning. Most of it does require planning, isn't it? Even if we are cooking and we need to make dal, so we have to plan in advance that, oh, we need all these ingredients to make the dal. So some simple activities in their daily life which they can do at their home, so that can increase, where some planning and organization is required, and so that their decision making can be improved. So we can do that. For memory, again, there are different tasks. Like for elaborative memory, we can ask them to uh, ask them to compile. We can compile a list of words, and we can ask give them so the words, and we can maybe ask them to find some associated words, and at the end the person can recall the words with the help of association. So let's say, we said chair, house, and we have given some association. Chair, it's a furniture, so maybe initially we can give some prompts, and gradually they will be able to remember on their own. Then frequency encoding, there are tasks that they are audited representation of list and common words that the patient hears and reports back. Then there is special encoding, again visual representation of some common objects, and they're exposed for a certain period of time. Then we remove them and we ask them to name it. Then there are you know oral presentation of words. They need to just listen, and then they can name the words. Okay, so BPSD is behavioral and psychiatric symptoms in, particularly this term we use in dementia, but there can be many psychiatric problems that is present with a like brain disorder as well, psychological disorder as well. So for that, these are different types of therapies that we can do, from behavior therapy to cognitive behavior therapy, based on again the functioning of the person. If there are memory deficits, we can use reminiscence therapy, validation therapy, music therapy. So there are lots of other types of managements that can be done, from relaxation to challenging their thoughts. Everything can be done, but again depending on the functioning of the individual. So I think that's it. Yes, now we'll share the Google link for assignment with you all. Okay, so I hope this class was fruitful and you were able to understand something about neuropsychology, and I hope it generates further interest, and maybe you all can implement some of it in your daily lives as well. It is going to help you improving your cognitive functioning. Right? Okay, so here comes the link. You can do the assignments with the help of this link. Let me just quickly explain the assignments to you. So the first assignment is to draw a picture of a brain. Again, I will accept answers from the lobes, but I would accept it when the functions are also written along with it. If you want to go into detail, if you can go into detail, maybe you can segregate it, and you can discuss the forebrain, hindbrain, whatever we have discussed. Maybe you can specify those areas as well. If not, that is also fine, but the lobes with the functions I would like to see. And there are few limits, so try to make the document that you're going to upload as smaller size as possible, otherwise it will not be able to uh, take that this Google form. And then there are questions which you will be able to understand. Okay, there is another activity where I have asked you to make a case study. Now again, this is just for the purpose of learning. You can do it with any of your friends or your family members. Just make a nice case history, and then you can write it down on here and submit. Right, whatever we have discussed during the case history and MSc, I want you to conduct case history and MSc. I have mostly given all the areas that you need to check, but the details of what it needs to have has been shared during the class. Right? Okay, again, I'm not expecting perfection, but I would like to see efforts. Then for BGT, there are two tasks, and yes, so again, I have given one case study from which I want you to calculate the MMSC score. Like I said, that it is available in public domain, so you can maybe check from there. You can refer back to my PPT as well, where we have discussed about the just a second. Okay, so where we have discussed about the, okay, some of you are saying that the link is not working. Let me see. Maybe you can check now. Let me know if the link is working now. Okay, yes. So now the link is working. You can just refresh it if for somebody it's not working. All right. So then there is one case study where I have given the detailed MSc. If you go through it, properly, you will be able to find the correct answer. Now, again, this is for the purpose of learning. This is not, for you to go and diagnose. I mean, do it on a patient. So you can maybe just take it as a learning opportunity and do the assignments, and all of you need to submit it before 3 o'clock on 15th of August, post which all the assignments uh, are going to be closed, and put the attendance, I mean, mark every day's attendance and the assignments as well. And these links of lectures are going to be available till as much time as we can give to you guys. So we will try to make it available. And yes, well, you are asking so many questions. I'm just getting a little confused. Okay, yes, a lot of you have questions regarding the assignment links till when it is going to be open. I have already said that 15th, 3 p.m. The attendance link, it gets closed every 24 hours, but we try to increase that time a little bit. So that's that. And oh yes, I said I will share the book names. Yes, these are the references. You can check these books if you get. They are very nice books to start, and you can go through them. Few of, I think, few papers also I have mentioned from where I have taken references. And anything else? I think that's it. Okay. Okay, somebody has a question for me. Are there any projective neuropsychological tests? No. If we need any projective test, then we are going to apply the projective test that we have, that is, TAT, Rorschach, that we need, and the purpose of them that is already discussed with you yesterday. So, okay, so I have taken a lot of time. Thank you so much for joining and being so playful. We have played a lot of things, so I hope we have learned a lot. Thank you so much. Yes. I think Roshni, you're on mute.
Thank you so much, Anuna. That was uh, a lot to absorb for all of us. And yes, I'm so sorry there was a glitch in the assignment, but now it's all working. Anyone who's having a difficulty, just refresh the same link which is there in the description and the comments is very much working. And like Anuna said, all assignment links will be accepting responses till 15th July, 3 p.m. All right. Even all other previous, yes, as someone has mentioned here, all previous assignment links are there in the description of that day's videos. So feel free to go back, spend your time listening to the recordings and finishing the assignments. And again, we give a big thank you to our Anuna ma'am for today's session. Tomorrow we'll be starting into a little bit of specific therapy sessions. So I think tomorrow will be about the third wave of DBT and ACT with Mimansa ma'am. So see you all tomorrow afternoon, same time, 3 o'clock. Bye. Email ID of Anuna ma'am is anuna.bordoloy@fortishealthcare.com. Bye.